and welcome to another episode of Infectious Conversations, the WVU Medicine Infectious Diseases podcast. I'm going to be your host today. I'm Contessa Howard, the lead antimicrobial stewardship pharmacist for the W Medicine Health System. And I'm accompanied by a very special guest, Dr. Katie Lambert. Katie, thank you so much for joining us today.
Thanks for having me.
Absolutely. So Katie, for our listeners, can you introduce yourself, talk about your role, how long you've been at WVU Medicine, and we like to include a fun fact on the podcast.
Of course. So yes, my name's Katie, and I've been with the WVU system for a few years now. So I started my PGY1 residency here back in 2021, I think it is. Losing track of time, honestly. So I did my PGY2 in infectious diseases right after that. And then after that was done, I went to Wheeling Hospital, where I'm currently the infectious diseases pharmacist there. So I do a lot in the antimicrobial stewardship as well as the OPAT space. So yeah, it's been rewarding and I've enjoyed it so far. Fun fact about me is that I'm actually terrified of pigs. It's a recently acquired fear of mine after being bit by a pig at a wine festival.
Oh my gosh. Was this like a big pig or like just a little pig?
If you've ever seen the one that walks on the rail trail,
oh,
you know what I'm talking about?
That is a large pig.
It's a very large pig. And now I'm terrified of him. So,
well, I hope that does not happen again. I'm glad you came out unscathed from the incident.
Barely, almost, but almost made it out alive.
Maybe we'll do a future episode of Infectious Conversation on animal bites, and we'll include your include your experience.
Yes.
Oh gosh. Well, great. Thank you so much for introducing yourself, and thanks for being on the podcast today. I think we're going to have a lot of fun and a really good episode. So today, our podcast is going to be focused on antimicrobial stewardship and antimicrobial prophylaxis in surgery. So specifically kind of thinking about how we're using antibiotics as primary prophylaxis prior to surgery to prevent infectious complications post-surgery. So, Katie, you talked about one of your main roles at Wheeling as an ID pharmacist is in antimicrobial stewardship. So can you elaborate a little bit on the role of antimicrobial stewardship programs and antibiotic surgical prophylaxis?
Yeah, so I think just in general, when you think about antimicrobial stewardship, it's all about how can we choose the right antibiotic at the right dose at the right time. So I think a lot of that can be done within the perioperative antibiotic space specifically. So at Wheeling, there's been several meetings with our surgical site infection subcommittee within the past few months to really help identify how stewardship can help optimize antimicrobial use in the perioperative setting. So a couple of things that we found is that we're not always meeting our benchmark in terms of allowing antibiotics to infuse within 60 minutes prior to incision, which is what a lot of the national guidelines like IDSA, SHEA all recommend, that you give that antibiotic within 60 minutes prior to incision to help prevent surgical site infection. So we're looking at ways to help with that. And then also we're looking at ways to help identify that the correct antibiotic is chosen. So for a lot of cases, we found that vancomycin was being used for surgical prophylaxis. And for a few reasons, that's not the most preferred agent that we can use, but it's actually cefazolin that's preferred in most surgeries.
Yeah, so when I think of surgical prophylaxis and antibiotics used in this setting, the thing that I think of is cefazolin, right? So say no more, that's really what that really is our preferred agent. So why is cefazolin preferred?
I think for a few reasons. So it's really well tolerated, like really good safety profile, low cost. It's able to be infused within a really short amount of time. So like you can either hang it to gravity over 15 minutes or even give it as a push over like 2 minutes, which in the busy perioperative world, we know that's very coveted. We definitely want something that we can get in fast before the incision. And then it also targets pretty much every type of pathogen that you would suspect in a surgical site infection. So like our skin and soft tissue bugs like staph, strep, as well as some E. coli, Kleb, and Proteus that can be implemented in some surgical site infections. So it really does everything you would need, and it has all those added benefits. So sort of going back to like the infusion time thing, when you think about that compared to something like Vanc that can take up to 2 hours to infuse, we don't often have that time. So a lot of the time the Vanc may still be infusing when the surgeon's making that incision. So you're not really getting any like benefit at that point if it's not been completely infused and then allowed to distribute into the tissues. And then thinking of other options or alternatives like clindamycin, there's been some studies showing that, especially in like the ortho space, I think it was, that when clindamycin's used, there can lead to increased surgical site infections just due to growing resistance among staph and strep species. And so one thing that I like to use a lot whenever I'm hoping to see like, you know, what is our preferred agent for which type of surgery is our surgical antimicrobial prophylaxis guideline on MedCompass.
Yeah. And I'm so glad you bring that up. So kind of a throwback to a previous podcast episode, we went over MedCompass and did a whole episode. But let's take a moment to pause and actually pull up those guidelines, okay?
Yeah, okay.
But we're going to go back and once again, you can just get to MedCompass either through a website here, medcompass.wvumedicine.org, or if you have it on your phone, download it as an app, you can just access it through there. So our infectious diseases guidance for surgical prophylaxis lives underneath surgical references. And we're going to focus on adult antimicrobial surgical prophylaxis today. But as you can see here, this document will pull up. This is something we actually are currently updating. So this will be updated with the most recent recommendations and any changes that have happened since our last update in October of 24. And that newest guideline will be posted here. Now that will be, once again, a system approved guideline. But just to orient our listeners to our guidance here, we have different types of surgery, right? All different types. So Katie, what would you like me to point out? What type of surgery do you think would be a good example?
Yeah, so if you want to pull up maybe like, we can start with, let's start with ortho.
Okay, great. So,
because that one can have some different features. Like if the person has like MRSA risk factors, you might have to consider something to cover that, you know, versus the normal thing that we'd use, such as cefazolin.
Sure. Yeah, and you can see here we have it broken down by procedure type, the primary regimen, and if there is a beta-lactam allergy. And then there's also the caveat of, like you said, you may consider adding vancomycin if a patient has a history of or known MRSA colonization or infection. And there's other information here on dosing and things like that. Yeah. I think another good example is, you know, sometimes cefazolin isn't the preferred agent depending on where you're cutting into. So I like to pull up like our urologic procedures, and that's where you might use our broader agents like an ampicillin sulbactam or Unicin. Sometimes we combine it with an aminoglycoside and Flagyl. But I'm with you. I go to this every single time. I'm trying to make look for a recommendation to make sure I'm using the right one. But I'm going to scroll back up to orthopedics. So, you know, I think that, you know, talking about the beta-lactam allergies and calling that out, you know, you mentioned earlier that while clindamycin or maybe vancomycin can be an alternative, often they're not preferred. So a question that we get a ton in pharmacy, or antimicrobial stewardship is, can I safely use cefazolin in a penicillin allergy? And what's your response to that normally?
Yes, so you actually can in most cases, I would say. Not in, so everything, I never say never, I guess.
Right. It's antimicrobial stewardship, it's ID, there's always a gray area, right?
Oh yeah. But I would say in most of the penicillin allergies that I encounter, we are able to use cefazolin. So the reason for that is because the beta-lactam allergies are sort of mediated by the R1 and R2 side chains. And cefazolin has very structurally different R1 and R2 side chains compared to all other beta-lactams. So it will not cross-react, and it's safe to use as long as the patient doesn't have a severe beta-lactam allergy, which would be Stevens-Johnson syndrome or TENS or acute interstitial nephritis, something that's very severe. We would still want to avoid it. Or if they have a direct cefazolin allergy, then you'd obviously avoid it. But in most cases, it is safe to use.
Yes, yeah. And I think that that's something that stewardship and pharmacists can play a huge role in.
Yeah.
No, go ahead. Go ahead.
One thing that I like to use too that's helped me like with my allergy assessments when looking at cefazolin and even just for any other beta-lactam, if I need to do like an allergy assessment on a patient is our toolkit that we have on MedCompass. So the beta-lactam allergy toolkit, as well as our cross-reactivity chart. So.
Yes, another great MedCompass feature. Yeah. So you want to show our listeners?
Yeah, that'd be great.
Awesome. So let's just go back up here to the top and we can very easily get into our antimicrobial allergy assessment. So as you mentioned, Katie, we have a whole beta-lactam allergy quick reference guide. For time today, I'm just going to pull up the cross-reactivity chart. But I love this chart because I think it's super helpful to have this visual representation of, looking at the patient's allergy, can I safely use another beta-lactam? So what I usually, when I orient people to the chart, just pick your allergy. So say we have a patient with a history of an amoxicillin allergy. Let's say it was hives, maybe 10 years ago was reported. Could I use cefazolin in this situation? So if I start over at amoxicillin and go across this matrix, I see a green check mark, which means that's safe to give, right? The really great thing that I love to show folks is that cefazolin has that green check mark all the way down for all the other beta-lactams. So like you mentioned, very structurally different. So in most scenarios with a penicillin or a cephalosporin allergy, you can safely give cefazolin.
Yeah.
Great.
For sure.
Great. Yeah. I like to print this out and like just put it in places so people can see it too. I used to have it printed behind my desk.
I love sending this to people, especially like residents, like medical residents. They love it too. So
very good visual representation. Great. So yeah, something great and this goes beyond even just surgical prophylaxis, but I think it's very, very important because cefazolin is our most used agent.
Yeah, for sure.
Another shameless plug for MedCompass.
Oh, yeah. we love our MedCompass around here.
We do. It's great resources. Great resources. So Katie, we've talked a lot about, what we should be using for surgical prophylaxis to prevent infections. ANSEF is our go-to most of the time. Other times we may be using different agents, but ANSEF's really our preferred agent. And we've talked a bit about how antimicrobial stewardship can play a role in the appropriate selection of that agent or any antimicrobial prophylaxis. So would you be able to elaborate a little bit more on ways that you all are working to increase appropriate antimicrobial surgical prophylaxis at Wheeling?
Yes. So through our surgical site infection subcommittee that I kind of was talking about earlier, we have come up with 2 pharmacy-driven protocols that we're hoping is really going to help optimize surgical antimicrobial prophylaxis. So the first one, I think, is something that you guys were already doing at Ruby. At least when I did my residency, we were doing it there. Is essentially for people with total body weight greater than 120 kilos, if they are ordered pre-op antibiotics with cefazolin prior to their surgery, then if they're greater than 120 kilos, then we'll allow the pharmacist to automatically adjust that from 2 grams, which is the normal standard dose, up to 3 grams, because there's data to show that there's inadequate tissue distribution at a 2-gram dose for our obese patients. So we want to make sure that we're optimizing that dose, and upon verification, the pharmacist is able to just adjust that up to 3 grams. So that was one protocol that we recently got approved and put through that committee. And then another one is sort of a newer concept that I don't think people have done at least within the system. But essentially what we're doing is that it's a protocol that's going to allow pharmacists to automatically adjust pre-op vancomycin to pre-op cefazolin if the patient has a non-severe beta-lactam allergy, and if cefazolin is the preferred antibiotic for prophylaxis for that specific surgery. So if you want to, we can maybe pull up that algorithm on that protocol to see sort of like, what the pharmacists are able to do with that.
Yeah, absolutely. I'd love to see this protocol, especially because I think that this is a great example of how we can empower not only those that directly work with antimicrobial stewardship, but what I call as our stewardship extenders. Our primary pharmacists.
Oh, yes.
So we got the protocol pulled up here. Katie, I'll let you talk through this a bit.
Yeah, so if you look here at this algorithm, which we won't look at the whole protocol, but just to sort of look at the algorithm that the pharmacists are using to help verify some of these antimicrobials prior to surgery. So let's say the patient is ordered pre-op vancomycin prior to a surgery, and they have a documented beta-lactam allergy. So from that, the pharmacist would follow this algorithm here. So keep in mind, this is if cefazolin is the preferred agent for surgical prophylaxis, which I would say in 99% of cases it is going to be preferred. So from there, they would look to see what type of allergy the patient has. So if it's an IgE-mediated reaction, which is defined here as anaphylaxis, wheezing, laryngeal edema, hives within an hour, etc., or if it's a reaction of unknown clinical significance, so that would be something like a side effect like nausea, vomiting. If it was remote, so greater than 10 years ago, family history, we love to see that.
Right.
Isolated pruritus, dermatitis, etc. If they have any of that, then the patient would be ruled in to be included in the protocol, and the pharmacist would be able to discontinue the vancomycin order and order cefazolin as a once dose pre-op according to the patient's weight. They would either order 2 grams or 3 grams. The only time that patients would be excluded is if it's a severe reaction. So that would be anything like SJS, TENS, serum sickness, the ones listed here in this blue box, a cefazolin allergy, or if the patient has known MRSA colonization. So if they either have past cultures that contain MRSA or if they have a positive MRSA nasal swab, then the pharmacist would then proceed with verifying the vanc order. So that's really the 2 protocols that we've come up with so far. So those went live at Wheeling back on the 7th. So we're excited to hopefully see the results of those and hopefully impact our pre-op antibiotic use.
Yeah, I think this is a great protocol and, a lot of time and work. And I think the one thing I'd like to highlight is the collaboration, right? So this has been in collaboration with your surgeon colleagues, your antimicrobial stewardship colleagues, anybody, who else was involved in this?
Yeah, anesthesia, some of the CRNAs, our director of pharmacy, Bob, our med safety pharmacist, Melissa. So yeah, it's been an infection control. I don't know, did you say them?
Yeah.
So yeah, a lot of stakeholders, and yeah, it was a pretty good collaborative group that it was great to be a part of.
Yeah, absolutely. I think that this is, and it goes to show, what difference that we can make with our presence in stewardship and, pharmacy too. So I'm anxious to see the results as well. I think this will be really good and have a very positive impact on our patients.
Awesome. Thank you so much.
Yeah, absolutely. Well, I think that rounds up another episode of Infectious Conversations. I really appreciate everyone listening in today. And Katie, thank you so much for your time, for joining us, and thank you for all your work that you're doing.
Thanks for having me.
Absolutely.